to Medics 360. I'm your host, Sherry Jampu, and with us today we have Dr. Neeti Rayzada, a medical oncologist and hemato-oncologist who is on a mission to improve cancer care in India. She's also the founder of National Research Network and is Cancer Foundation supporting underprivileged cancer patients. Dr. Neeti, thank you so much for your time with us today. Now, what exactly does the field medical oncology focus on?
So oncology in general focuses on cancers, and medical oncology focuses on chemotherapy, biologic therapy, hormonal therapy, and newer therapies like immunotherapy and CAR T cells, and of course, bone marrow transplants. So when we talk about medical oncology, it's generally solid tumors. And when we talk about hemato-oncology, it's generally blood cancers like leukemias, lymphomas, myeloma, etc.
Yes, that's a very special part of the field. Now, why did you choose this specialty in particular?
My father was a doctor, so I was always clear that somehow very inspired by him, and I wanted to be a doctor. But when I started medicine, I realized that I needed a blend of research and something which has innovations all the time. And oncology has innovations on a daily basis. It's not on a yearly or a decade. It's every day there's something new. It's evolving. So I needed that interaction. I did not want a desk-like job like a radiologist or pathologist. I wanted interaction with patients, and oncology also gave me a lot of new drug discoveries, newer treatment modalities added in, and of course, a lot of research. And that's why I chose oncology.
Right. So can you explain to us and talk us through what a typical day looks like for you from the moment you get into work, let's say?
I start nowadays after COVID, it's kind of tough because early morning I get up and I take teleconsults or video consults, sometimes starting from my house. And then in my car, I tend to do the remaining mails, which I need to wrap up. I start my day in the morning kind of with rounds, and rounds means going to inpatients or admitted patients bedside and seeing how they are doing. So we start in the ICU, which is intensive care unit, and the transplant unit, which are the sick patients, then go in the ward, which require a little step down care, go to the daycare and see the patients who are admitted there, and then start my outpatient. So after finishing my inpatient round, I see patients in one hospital and then the other hospital.
Now, what are the significant advancements you've seen in hemato-oncology most recently?
Again, as I said initially, that oncology is an ever-evolving field, and every day they are not just newer drugs, they are new devices, they are new techniques which are evolving. And most recently, we have everything directed towards precision oncology or precision medicine. So we have unique titrated therapy for every patient. Every patient is unique, every individual is unique, and of course, the tumor is also unique. Tumor is heterogeneous. So you have the same stage, two women with the same stage of same cancer, but both are treated very differently and uniquely. And for that, there are many modalities of determining. So you have epigenetic or environmental factors, which we have to put in account. We have to have inherent patient factors to put in account. Then genomic factors, like whether there are any molecular expression of biomarkers which can treat the cancer better or more accurately. So these drugs are known as targeted drugs, or if immunity modifying drugs known as immunotherapy, which is coming up in a big way. Then beyond this, we think of protein expression known as proteomics, microbiomes, transcriptomics. So this is an era of multiomics in which many things are integrated before we treat the patient. And of course, we talk about artificial intelligence and machine learning. And the role in medicine probably is most evolving in oncology and hematology, where we have to put various data together and come up with useful models and useful algorithms to treat each patient.
So how has the latest treatments such as AI helped specifically? Do you see a rise in cancer cure because of these new treatments?
Yes, the result of all these newer techniques and newer technologies is improved patient survival. The quality of life is better. The journey of cancer is easier, with lesser symptoms and more control. So yes, in terms of cure, the results are better. We have more like more organ conserving treatment. So cosmetically, the person who actually is cured is not deformed. So later on, psychological impact is less. The social and occupational impact is much less. The results, even in advanced stage of cancer, is much more remarkable. Just a tablet can have survival, improve the survival for decades. So yes, all these techniques have improved the results and also improved the cure rates.
That's very good to hear. Now, what are the different challenges you face as a medical oncologist when treating children versus adults?
Sherry, this is like every age group has very unique challenges. I mean, when you interact with kids, we have to understand that kids are very resilient, but it's not like they don't understand the scenario. When you have parents talking secretly and the kid is outside your room and the parents want to know what is the prognosis, half of the time the kids absorb sentiments or absorb emotions and they understand something is going wrong. So sometimes talking to them is better than trying to hide facts from them. But the interesting part about kids is quite a few cancers are have very good results. Cure rates are significantly higher in pediatric cancer, and in fact, including very aggressive treatments, they can tolerate much more easily. So pediatric patient in general have a very unique population of curable cancers, highly treatable cancers. Even if they have toxicity, they are very resilient. So the results are much better. But the bad part is they may have hormonal issues, which probably can cause problems later on in their life. Sometimes growth retardation or some kind of physical attributes which are very different from other patients.
Right. So that's good to hear that, they're strong and their immune system can handle the strong treatments overall. Now, you're specialized in treating cancer patients with infections such as COVID-19 as well. How did you tackle that during the pandemic?
COVID times were tougher than usual times for us because we had COVID in one side and obviously we had oncology patients in the other side, which needed priority and which needed to be treated. So how we treat a cancer patient during COVID is we streamline the important and aggressiveness of cancer. If there's a blood cancer or hematological cancer, which is very aggressive, then the priority is treating the cancer. We cannot wait for a certain length of time. There are certain advanced cancers in which you can change from IV to oral, and we did that. We actually had certain situations which we had to go to the houses. My team, I mean, my support staff who would go and treat the patient. There were a lot of supportive care in which patients are not well and they needed extended stay in the hospital because bringing them to the hospital itself was a challenge. Quite a few elder patients who never had any support and not even a public transport facility which could bring them to the hospital. So our even ambulance staff was working round the clock. And of course, we had the other challenge was these patients having cancer. So if you have uncontrolled cancers, you're already immunocompromised, then the chances of catching infection is higher because you're coming in contact to other patients who could possibly carry this infection. So yes, there were routine screening for all the patients during that time. Even in daycare admission in a stable patient, we would routinely screen all the patients.
Right. So should cancer patients in such instances, check and monitor their health regularly, or should they only reach out when they have symptoms?
All patients are given unique instructions. So if there are cancers which compromise your immunity in a substantial way, then they have certain prophylactic treatment offered and they are told what are the red flags and when you should report to us. So everybody is treated differently. If a stable, solid cancer is there, then we don't routinely test them and we test them only when they are symptomatic. But a patient who is actually on blood cancer treatment and who's already on induction therapy or the initial phases of therapy when the cancer is not under control, they may require regular screening for quite a few things.
Now, medical oncologists are usually in a hospital setting. What is your opinion on, private practice for medical oncologists? Do you see a lot of that, or do you see that happening in the near future?
Oncology as a specialty is hospital based. The reason is that it's a multimodality treatment. It's not a treatment which one subspecialty should handle. So we always have one patient in which tumor board discussions are done when all subspecialists sit together and come with treatment plan for one individual. We need medical oncologists, surgical oncologists, radiation oncologists, nuclear medicine, oncopathologists. Everybody sitting at the same platform and discussing. Generally, hospital-based setting in which you have good facilities of molecular oncology, an intensive care facility, a high dependency facility, HEPA filters for transplant units. These are recommended. So these are one aspect. But one can always have a clinic in which you do preliminary screening and then get the patient to the hospital. So private practice is possible in a certain way, a certain limited way.
Right, thank you. Now to our final question today, what is the most rewarding part of your field, especially when it comes to treating underprivileged cancer patients?
Sherry, this question I would say is in general, I think my specialty comes with a lot of emotional challenges. And oncologists also present, I mean, quite early in their career as burnout because of so much of emotional stress going on. And whatever we see in patient also reflects in us sometimes. I mean, when we see, when a patient has been with us for several years and now they are for whatever reason not doing well, it does leave a lot of impact in the entire team. But then the positive aspects are 50% of all your cancers are curable. And it's unlike diabetes or hypertension in which you constantly see them, but you have treated for a certain period of time and now they are out of disease and living a healthy life, a healthy, fruitful life. So when you meet such patients and when you interact with them, it's quite a positive, very encouraging feeling.
Thank you, Dr. Neeti. We'll leave it there for now. Best of luck for your future, and it was lovely speaking with you.
Thanks so much. Thanks for inviting me today.
Of course.